Angeles. And on behalf of the International Women in MS Executive Committee, I'd like to welcome you to our weekly COVID-19 and multiple sclerosis call. We're very excited to have you all here. We've had a series of wonderful calls connecting colleagues from all over the world, and hopefully this week will be just the same. Just a few reminders. We will record the session to post on the iWiMS website, so please keep that in mind. And you can also find old calls there if you'd like to take a look at those. People who are not presenting will be muted. If for some reason Zoom unmutes you, please do mute yourself. Presenters will be unmuted when it's your turn to speak. Please use the chat function to ask questions. So if you look at the bottom of your screen, there should be a little button with the word chat. If you click there, you can send questions to everyone or just to me, and I'm happy to share those with the group. If you are going to take the information you learned from today and share it in your scientific circles or on social media, please do acknowledge the presenters if you're citing their data. To the presenters, so please, if you're going to share your slides, you can see that bottom button on your screen called Share Screen. When you're done presenting, please unshare your screen so that the next presenter can share those slides. With that, hopefully we're going to have an open and timely discussion and use this forum to allow each other to learn new information as it becomes available in this time when things are changing so very quickly. We are recording, and today's date is April 22nd, 2020. First, I'd like to invite Dr. Jeffrey Bennett to share with us some information on the immunology of COVID-19 and how that pertains to MS. Dr. Bennett, are you on the call?
Yes, I am. Can you hear me?
Yes, we can.
And I will share the single slide that Fabienne told me I was allowed to present, and I hope everyone can see it now. Let me know if I'm not appropriately sharing, but I apologize for the crowded nature of it, but when I'm limited to a single slide, I wanted to cover a couple of details that Emmanuel asked me to review. And I would say, rather than information, a lot of this is based on obviously the limited information that we all have at this time, as well as my speculations and current opinions about MS therapies. First, I wanted to concentrate on this left hand of the slide, and particularly about MS therapies and COVID-19. There's been a lot of chatter out there, deservingly, and what I wanted to present is some opinions. And when we think of MS therapies and COVID-19, we can think of it best put on two different levels. One is infectious risk, and one is disease risk. And I'm going to come back to these when we get to the right side of the slide when we talk about immunity to SARS-CoV-2. And right now, there's very limited data to suggest that infectious risk is limited in any humans around the world now, except for those who have had the disease. And that is that the immunology against the SARS-CoV-2 virus, particularly neutralizing antibodies, which are directed against the spike protein, do not show in some of the series done to date by independent investigators using recombinant protein and recombinant spike protein binding domains that there is any immune reaction against the spike protein in patients who have previously been infected with naturally occurring coronaviruses. And so therefore, I think the infectious risk is pretty uniform across the population and not necessarily accelerated significantly in MS patients or in MS patients receiving therapy. Now, with that said, is there a disease risk for MS patients in terms of the amount of virus that might be necessary in order to overcome the system and present with clinical disease? That's quite a different question, and is often in many viruses determined not only by viral serology, which sometimes can only have relative protective effects, but also cell-mediated immunity, and how that may combine to limit infectious risk could be determined by relative lymphopenia. And while there are certain MS medications, particularly alemtuzumab and cladribine, that we consider during the acute dosage interval to have prominent lymphopenia, whether the relative lymphopenia that ensues after administration contributes to that disease risk remains to be determined, but should make all of us think twice about acute administration, obviously, during the COVID-19 pandemia. The third aspect is whether MS therapies themselves contribute to what is the ARDS multi-organ failure, quote, cytokine storm hyperinflammatory response. And this is what I've outlined in terms of my understanding of this from literature and discussions with colleagues, is that basically you have a process which begins here in the lung with infection of alveolar cells and release of IL-1 alpha from destroyed cells associated with a prominent cytokine release and chemokine release to attract the rest of the immune system to this injured site. One of the first steps in that process appears to be a prominent release of GM-CSF and IL-1 beta, which upon stimulation of the bone marrow often leads to this first step, which is the prominent release of myeloid lineage suppressor cells, particularly in an amplification of immature monocytes and neutrophils, which then travel back to the lung here to result in what is the initial capillary leak syndrome and the activation of prominent other cytokines. I've listed many of them here: IL-1 beta, IL-6, 12, and 18, and TNF-alpha, and associated chemokines. And here the action of the NLRP3 inflammasome, particularly for the processing of IL-18 and IL-1 beta, is important for the feedback loop of what is this amplified cytokine storm. And then with the processing and output of some of these cytokines, particularly the group here, resulting in the acute phase reactant elevation in liver and the prominent role in hepatitis. And finally, sometimes with the resurgence of interferon gamma, the hemophagocytic syndrome can result in prominent bone marrow suppression. And we look at the types of these cytokines and in their broad elevation in this whole process as it's considered. The therapeutic interruptive points here are not one that really emphasize many of the cytokines that are modulated in MS. One can think of interferons as being potentially beneficial as they depress the production of IL-1 beta and possibly a potential protective effect when it comes to maybe patients having less opportunity for the cytokine storm. We're not really using, as we are in NMOSD patients, IL-6 receptor inhibitors, such as tocilizumab, that could necessarily be quite useful in patients in this region of their illness. And also the oral inhibitors that are now in clinical trials for NLRP inflammasome and IL-1 beta inhibitors such as anakinra could be possibilities, but I personally don't see much of the MS therapies modulating this axis of cytokines tremendously with regard to a helpful or hurtful scenario with regard to the cytokine store, except for the possibility of interferon beta and IL-6 receptor inhibitors. And so this is a unique situation in which many times we get cytokines elevated. We only call it necessarily cytokine storm in association with end organ damage. But as we look forward, we may think about some of these ratios as possibly exacerbating other disease activity, particularly in the light of accelerated GM-CSF and our current considerations of MS disease activity, and IL-6 when we think about NMO and interferon axis-mediated activity. So in the interest of questions, I want to address also the issue of potential MS therapies and SARS-CoV-2 immunity. Now, many of us are aware of patients, having seen or taken care of them, who may have had asymptomatic or mildly symptomatic presentations. The questions regarding those patients' reactivity to spike protein in terms of the development of neutralizing antibodies are not clearly evident in that they have a more robust or less defined response. And it's also not clear if immune reaction per se on a newly defined immune response may be as important in those versus a potential cross-reactivity to some other aspect of the coronavirus from past infections, combined with a robust cell-mediated response that was preventing infection rather than, preventing disease rather than preventing an infection. And so I want to discuss this immunity aspect with a couple of definitions up here on the right. When we think about patients developing immunity, we have to think about correlates and how we use those in our general practice. That is, a correlate being a specific immune response that we're going to measure that's going to tell us whether a patient is protected. And that could be absolute protection, as we have with some organisms, or relative degrees of protection, as we can see based on some immunizations previously noted with even Lyme disease, rotavirus, and other antibodies against viral and bacterial causes. And when we think about co-correlates, we have to think about sometimes immune responses that are not necessarily protective of them themselves, but synergistic with other correlates, such as cell-mediated immunity when it comes to varicella zoster virus, and cell-mediated immunity as it comes to prior coronavirus infections, particularly SARS-1. And then those surrogate markers, those markers that don't necessarily correlate with the exact immune response, but may be helpful measures of that immune response. And that can be seen with some rotavirus neutralizing antibodies. So think about all these different levels. And when we think about these correlates, remember that we have absolute antibody infectious protection that we see with agents like measles virus and certain bacterial infections. But many of these can be quite age dependent. And when it comes to certain bacterial infections, remember that as patients age, their antibody response is lower, but their protection against these infections often becomes cell-mediated and takes a shift. And this is particularly noted with zoster virus. Antibody dependency can be important, what subtype of antibody you make, and the location of that antibody, whether it's particularly IgA or IgG, sorry. And T cells and their disease response in terms of protection, they're often thought of protecting against disease but not infection, but they can be quite important. And antibody waning of immunity to zoster and SARS-1 are quite well noted after several years, but cell-mediated immunity appears to be robust for some time and appears to correlate better with loss of protection against these infections. And co-correlates such as antibody and T cells together are prominent with zoster infection. And I think as we think about our MS therapies and the possibility of vaccination and natural immune response, we have to take all of these into consideration, and that some of our patients may be more protected than we think when some of these surrogates either have no information or limited information with regard to whether these correlates are absolutely protective or indicative with another co-correlate of that protection. And then finally, I put down some of the information we know about MS therapies and vaccination studies, which are quite limited. And what I wanted to point out is that, interestingly, in the limited abstract data on the Ocrevus vaccination studies, reduced antibody correlates and surrogates were noted to novel greater than amnestic responses. But the response to the flu vaccine was not particularly aggregated in that study, and that could have been from common antigens to other flu experiences by the patients. So this may be one avenue in which other SARS epitopes, not necessarily the spike protein, might allow for some cell-mediated protection for infection in patients. And I'll stop jabbering and let anybody have any comments. So.
Thank you for that excellent and concise review of a lot of information. Does anyone have any questions? You can type them in the chat function. I'll be happy to share.
Okay, I can't see the chat box, so please let me know.
Yeah.
And thank you, Jeff, to have prepared one slide. I didn't mean a single slide really to enforce, but thanks for accepting the challenge.
Just means you all have to get glasses like me to see it.
Exactly. So I have a question for you. So do you think there's been concerns that maybe if the infection is encountered by patients who are on disease-modifying therapies, it may decrease the immunity they mount to the infection and possibly would put them at risk of a second infection in the future? Do you have any hypothesis about that being a real concern or not?
You know, I think that what we have with regard to data, of course, is very limited. And one of those pieces of data, the old McCarthy neurology publication from 2013, is about the closest one might get to at least looking at that on a very limited amount of responses. Number one was the absence of any indication that past amnestic responses were mitigated by a prior therapy. And, but you have to realize that the mean duration after infusion was about 18 months in that study. The other was that novel responses, at least to T-cell and non-T-cell dependent antigens were no different. So I think that we have, at least for most of our therapies, enough of a composite immune system to mount a response. The question will be at what level that response will be with regard to also how that vaccine is developed. Many vaccines are much more effective if they have a complete infectious armament, at least array of proteins, such as in a attenuated live vaccine versus a inactivated whole vaccine versus recombinant protein. But I think that for even patients who experience an infection and are on therapy, there's no strong indication that it's impossible to develop an immune response, even on B-cell depleting therapies. And what we need to know is how these correlates, what we measure as indications of immunity, really respond to protection against infection versus disease.
There are a couple more questions coming through. So one is regarding this McCarthy study on alemtuzumab and vaccine. Does your slide indicate alemtuzumab patients do not have a decrease in response to vaccines, and when were the vaccines given in relation to the treatment course?
In terms of the treatment course, the paper was extremely vague on the exact profile of the amount of patients in terms of their exact timing of the vaccination versus administration. What was given in that was a broad range, and the range covered from 2.5 up to 30-some months after immunization. And I think that there was patients as early as 2.5 months, but others were sort of limited to the average of about 18 months. So well after the time for the general T cell and B cell populations to have recovered.
Okay. And then a question on CD20 therapies. Do you think that they have a high increased rate of coronavirus infection due to the decrease of B cells and not possible interaction with T cells?
I'm sorry, could you repeat that? My connection sort of.
Yeah, the question was regarding CD20 therapies.
Mm-hmm.
So the question asker asked if they have a high increase of coronavirus infection rate due to the decrease of B cells and not necessarily due to the interaction with T cells.
So I think in terms of our B cell therapies, we have very limited evidence that they promote an increased risk to primary viral infections. We do have a prominent evidence that they increase the risk of viral reactivation within the immune system, likely not by decreasing, the titer of protective neutralizing antibodies that someone has, but by somehow their effect on cell-mediated immunity and surveillance of those viral infections, combined with perhaps a limited response that might occur once a virus is reactivated. But no one has gone around talking about how horrible the influenza infection rate is in CD20 treated MS patients over the years. And I think that when we look at viral issues in terms of infection rate with CD20, minus a couple of incidental reports in the rituximab and Ocrevus literature, excluding those on concurrent chemotherapeutic regimens, of which the addition of rituximab didn't add to any viral infectious risk. Mm-hmm. You have the issue of the fact that the response to new immunogens, obviously in the production of novel neutralizing antibodies, might be limited, but still may allow a cytotoxic response, or at least a cell-mediated response, to develop that might be partially impaired by the lack of associated antibodies for opsonophagocytosis, which reduces with age as well.
Great, thank you. Last question, this is regarding the trial of fingolimod as a treatment for COVID-19. So the question was, I understand it is aimed at ARDS, but when we have more targeted therapies such as anti-IL-6 and anti-IL-1, what philosophically or theoretically do you think will be the role of fingolimod in treatment for COVID-19?
I mean, that's an interesting question, and I think that with regard to its effects on immune system, at least circulating cellular populations, the ability to limit some of the helper response that might be promoting the cytokine release could be beneficial, but I'm a little bit worried about limitations on immune cell lymphocytic trafficking to end organs that may be needed for protection in terms of fighting off at least the cell-mediated response to the virus. But I think that overall, the timing and the onset of action might be a little bit slow for acute therapy. I think that if I had to rank therapeutic interventions at this time that might be the best, and in the order that they might be used, I would target the NLRP3 inflammasome first at those earliest times of infection, followed by anakinra with IL-1 beta, followed by IL-6 in terms of how these cascade floods tend to open up, and consider sort of a stage therapy at different times based on a rising level of acuity.
Okay, excellent. Thank you so much for that presentation. So if you can stop sharing your screen, and we'll move on to Dr. Fu-Dong Shi from China, where it's currently in the middle of the night. So thank you so much for being with us and for presenting your data and your experiences so far. Are you on the call? We may have lost him. Okay. So maybe we'll circle back and move on to Celine from France. Are you on the call and available to share?
Hello, hi everyone. Yes, I am available to share. Let's find out again where the button is there. Okay. So, so this will be a quick update from the information I provided during the last 2 weeks, the last 2 meetings. So this is the data from the French registry of patients with multiple sclerosis or NMOSD infected with COVID-19. On the last extraction, we had 208 MS patients, 5 NMO patients. Among them, so we have PCR for SARS-CoV-2 performed in almost half of the patients with MS, and among them 83% of the patients had a positive COVID-19 PCR. And among the one who had a CT, thoracic CT, 66% of the patients had typical ground glass opacities on the scan. So this is just an update also about the figures I already presented last week. So currently on the last extraction, we had 6 patients who died from COVID-19. 1 patient who was in intensive care with mechanical ventilation, and we have just been updated that this patient went out of the intensive care unit. The symptoms were quite the one expected for this infection. And this is a distribution of disease-modifying therapies. So I have an additional slide where I detail the demographics of the patients who had the most severe COVID-19 outcome. So we used an ordinal scale for COVID-19 severity. So 6 is the patient who was in intensive care unit I was just mentioning. It is a female, 31 years old, relapsing remitting MS. She has a short disease duration, just 1 year, and she was on ocrelizumab. And the comorbidity for this patient was that she had an obesity. The other patients were the ones who died from COVID-19. All of those patients were on a progressive course, either a secondary progressive or primary progressive course. And usually they had either a quite high EDSS score, and some of them had also comorbidities. Like this patient who had a chronic leukemia, colorectal cancer, cardiovascular disease. One of the patients was on rituximab but stopped 18 months before COVID-19 onset. So this is the data I wanted to share with you tonight.
Thank you for that. There are a couple of questions. So that slide that you were just looking at, the 7. So the scale, I guess, is the 7 mean death. That's
yes.
Okay. And the slide that you were just showing of those patients A through G, those were just the more severe outcomes. They were not necessarily all patients who had died, correct?
Sorry, I missed that.
That last slide you were showing us of the patients A through G who had the most severe outcomes.
Yes.
Those were not necessarily all patients who had died. Is that correct? They just had the most severe form?
The first one is a patient who was in intensive care unit and she had ventilation. She has now tracheotomy and really very severe disease. The other one were the one who died. So 6 is the one with mechanical ventilation, and 7 is the one with who died from COVID-19.
Okay. And then another question about the design of the registry. Why have patients that have been tested but had a negative PCR been included as COVID positive?
Yes, so those patients had a diagnosis of COVID-19 because either of the scan, the thoracic scan, the sensitivity for the PCR is not, it's far from being 100%, and we have quite a lot of patients, not specifically MS patients, but in general, who have 1 or even 2 negative PCR, so that can happen. And also for some of the patients, the test was performed quite late from the symptoms onset because the PCR were not available for the mild forms before. And so what we did is we really went through all the negative patients and decided if we include them if the COVID-19 is highly suspected because of the CT, the chest CT, or highly suspected because of symptoms, or for example, someone, a relative who was diagnosed with the COVID-19. So that's why they were kept in the analysis. Overall, we just included 1 patient from the registry.
Okay. So a very high clinical suspicion coupled with a low sensitivity of the PCR.
Yes, yes.
Okay, great. Thank you so much. That was excellent. Next, we have the North American Registry. So Amber or Lauren, are you available to update us on that?
I can start with the North American one. So this is, so I'm presenting the data from the COVI-MS registry. This is a North American effort to collect MS COVID cases. So just as a note, in case you don't know, this is a clinician-based data collection of de-identified data from healthcare professionals. So the number of cases that we have collected have doubled since last week, if you were on the call. So we've gone up to about 92 cases have been collected. We're seeing a 3-to-1 ratio of females to males, and the mean age is about 50. And so we have a large proportion of the cases are Caucasian. However, we do have over almost a quarter that are African American. And then as far as for the confirmed MS, as you saw, we have some other diseases in there, but if we just focus in on the MS cases, the majority are relapsing remitting patients, and they are taking a disease-modifying therapy. As far as COVID-related factors, the majority of cases are currently lab-positive COVID, with about almost 80%, and then overall, 40% of those cases have visited an emergency department. Over a quarter have been hospitalized. And we do have fewer reports that were admitted to the ICU and required ventilation. And we have less than 5 deaths have been reported as of now.
Excellent. Any questions? I have one question. How are you getting the word out about the registry so people know to input their patient information?
Sure. So both the National MS Society in the US have been, and the Consortium of Multiple Sclerosis Centers have been advertising pretty widely with their lists to try to catch a broad range of things. There's been some postings on the ACTRIMS forum, and so I think that's how most of our cases are currently coming through at this time.
Great. Thank you. Okay, next we have Nick from the MSIF.
So I don't have a lot more data to share tonight compared to last week. Well, to remind people who don't know, MSIF got together with the European Charcot Foundation and the MS Data Alliance really to provide a platform for data sharing so that all of the data collection efforts around the world we'll be able to pool data so that we'll have the kind of data power that I think we all want much more quickly than if it was just left to national efforts alone. That data is being collected by registers that are clinician entered as well as patient reported. The good news is that we have completed data imports from our first 2 test registers. So that's the Swedish MS registry and iConquer MS. So we're now definitely ready to go. We have the model, it works. So registers anywhere in the world now can share their data with us. I should say that we do also provide a direct entry track for people who don't have or are not willing to use existing registers, but that's not our preferred route. From the direct entry, there's nearly 900 people that have been entered, mostly patient reported, although some by clinicians as well. And we have roughly 10 times suspected COVID-19 compared to confirmed cases, which is exactly what we expected. But next time, the QMentor platform will provide a visible dashboard that people will be able to see the data that has been shared at a very high level. But it will take some time before we've been able to really process and assess that data to ensure its quality before we then start to release what that really means for COVID-19 MS and the treatment of MS. But the platform works, it is up and running, and we are very pleased that major registers with worldwide reputations have now completed the data export to us.
Fantastic, thank you. Next I have Lauren from New York City, which is the hardest hit area of the US, which is the country with the most number of cases in the world right now. So Lauren, are you available to give us an update on how things look in your part of the world?
Yeah, I'm just trying to get my slides up. Interesting. Just give me 1 minute. What I can do is, yeah, just not sure it's, yeah. So basically, do you see my slides or no?
Only
We
see
see the title
background.
slide.
Yeah, okay, great. So that's good. So basically, we have 3 centers within our NYU complex that are in Manhattan, Brooklyn, and Long Island. And so we have right now 60 patients that we've have some information on. We've got 77 that have been reported to us, but we haven't gone through all those cases. 57 have MS, 43 are relapsing remitting, and 12 secondary progressive, 2 primary progressive. 6 of the 6 have pediatric onset MS. And then we have 3 other neuroimmune patients, 1 neurosarcoid, 1 MOG, and 1 Creon. So in terms of the demographics of these patients, and they come to us either because in the course of our telemedicine visits, we're being told that they've been exposed and infected or confirmed, or they're coming to us from being in the hospital and the hospitalists have a list of all our neurologic patients who have become infected. So the patients have a mean age of 45, 61% are female, 1 is pregnant. She did very well, by the way. 60% white, 33% black, 4% Asian, 22% Hispanic. And in terms of just a little bit looking just at those patients from Manhattan or New York City and comparing their demographics, and this is very, very rough, but it does look like among our patients in Manhattan compared to our usual MS clinic, in Manhattan, there may be an overrepresentation of African Americans. Whether or not, I'm less certain about the anti-CD20 therapy, where about a third of our MS clinic we think is on these therapies, but that is a rough estimate, very rough, so I'm not sure about that number just yet, whereas 46% of the Manhattan COVID patients are on anti-CD therapy. Very unclear if that's a real difference. The African American proportion, may be true. So this is just showing that of all our patients from the 3 campuses, 60% were anti-CD20 therapy. A mean duration of MS was 16 years, and most were on a disease-modifying therapy of one sort. The symptoms were pretty similar to what we've heard before, cough being most common and fever. Many patients have worsening MS symptoms as a presentation. A quarter had anosmia. And, in terms of getting to the issue of whether these patients were confirmed positive, not all patients were tested, but almost all had either a direct exposure to a family member. But in our hospital, we have a very high false negative rate of about 30%. In terms of severity, we had about a third of the patients have pneumonia. 2/3 were managed at home. 30% were evaluated at the hospital, several admitted, several discharged.
Lauren, I'm sorry to interrupt, but we were seeing your second slide. Are you looking through more slides?
Oh, yeah, I am. Okay, sorry about that. Thank you for telling me that. Let's see, why is this not working? Okay, still just seeing the second slide?
We're seeing this. Oh, now it's working. Yes, now we see more data.
Okay, so you're seeing the 77 patients?
Yes.
Yes, with the pie chart.
Okay. The demographics?
Mm-hmm.
Yes.
Okay, sorry. So basically just that there were a little bit, maybe more African Americans among our COVID patients than our usual MS clinic. I'm not sure that the percentage of those on anti-CD20 therapy is different. 60% were on anti-CD20 therapy of all our patients who were COVID infected, but I don't know how to compare that to our general MS population. And in terms of the most common symptoms, cough and fever, and about a quarter had worsening, or a fifth had a worsening neurologic symptoms of MS. High false negative rate, but of those who were tested, 57 were tested, and of those who were tested, 90% were positive. About a third had pneumonia, and then of those who were hospitalized but not in the ICU, basically we had patients ranging in age from 45 to 61, and most who were in the hospital had some kind of ambulation problem, but there were 2 who were not, who had no problems with ambulation. Of these hospitalized 9 ICU patients, a number of them have recovered, 2 were still waiting for follow-up, and 1 is definitely in the hospital still. In terms of patients in the ICU, we've had 5 patients who were either in the ICU or who were deceased. And these were all but 1 or all but 2 with severe impairment in ambulation. 1 patient who died had a course of steroids a week before, quote, worsening MS symptoms. We think those MS symptoms were probably a pseudo relapse. She subsequently passed away. We have a 66-year-old on Ocrevus who had testicular cancer, former smoker. He also is deceased. A 65-year-old who was in a wheelchair. He's still in the ICU. An African-American on Tisabri who had risk factors of hypertension and hyperlipidemia had a cardiac arrest while in the hospital, and then a younger patient, 42, but tetraplegic, who was found, who really was passed away before even getting to the hospital. We have some pediatric onset patients. Most of them are doing extremely well, but we do have, out of these 7, one girl who is obese, who's hospitalized on an oxygen rebreather, and another who is still ill, also obese, not yet recovered, but not hospitalized. And then we have another girl who is hospitalized on rituximab since 2015 and on a nasal cannula right now. So that's basically what our experience is so far, and we will get this information into the National MS Society registry, but it's going through our IRB process right now. Takes a little bit of time, but we're collecting them as they come in.
Thank you very much for that. It's very interesting, especially the pediatric MS data. I don't think I've seen a lot of pediatric MS COVID cases, so it's good to see that, at least that information. We do have quite a few presenters left, so I'm going to move us along. We do have Fu-Dong back on with us from China. We've been eagerly anticipating this information since they're a little bit ahead of us chronologically with COVID-19. So Fu-Dong, would you mind presenting what you have?
Lauren, can you unshare your screen, please?
Yeah. All right. Let me try to do that. Damn. Okay, hold on. Okay, what I'm gonna just having some issues.
You may have to leave the meeting and rejoin us if you're having trouble on sharing your screen.
Lauren, do you see the red button on top of your screen? It should be in the middle. I am going to remove Lauren from the meeting. I'm sorry. Trying to remove it. Is that what?
I don't think it did. Are you able to switch the screens, Fabienne?
I'm trying to stop Lauren to share, but it doesn't work.
So I just called Lauren, so she's going to leave the meeting, but maybe we can, do you want to take a few questions, Marwa?
Yeah, the questions were directly related to just showing the slides that didn't show up from her presentation. So does anyone else have any other questions for any of the presenters who've gone so far? I think one of the points that Georgina brought up is relevant for all the registries, which is how we're classifying MS worsening as either a relapse or a pseudo-relapse, given that they're acutely infected at the time. So just something for us to think about as to what are the criteria for determining whether somebody is having an MS relapse at the same time as their viral infection. I see a hand raised from Mag. Do you have anything that you wanted to
good
share?
evening to everyone. I have two questions actually. In the first presentation, I just wanted to ask that we know that the interferon 1 type pathways are inhibited, and the question is it possible to assume that using interferon beta could be or could have some protective effect on the virus infection? The second question is to the French registry. There was no specification of the DMDs used. The second presentation, we didn't see anything about the distribution of the DMDs among the patients that were shown in the registry. Thank you.
Jeff, are you available to take the first question?
Yeah, can you hear me now? Am I unmuted?
Yes, we can.
Yeah. Okay. For first, with regard to whether interferon beta therapy itself could prevent infection, obviously a possibility given the natural antiviral action of that cytokine. What I would impress on everyone with all these registries is that evaluating such a question, looking at the relative proportion of interferon-treated patients in the MS community and their infection rates versus the general population, will not only take a good serology test, which some good and many bad are coming around the corner, as well as a significant number of patients that are infected, because just looking at the powering of such a study to even detect a twofold risk in a small number of patients, i.e. 100 MS patients on beta interferon and 100 and the population control would take an incidence rate of roughly 20%. And as you get to smaller seropositive incidence rates, of which maybe 5% it's looking like in many preliminary studies, we're talking about needing about probably 600 patients to really look at levels of risk increase at 1.5-fold. So keep those in mind. It's a possibility. With regard to SARS hyperinflammatory, COVID-2 hyperinflammatory syndromes, interferon beta for patients on board has the the effect of inhibiting NLRP3 inflammasome production of IL-1 beta, and so it's a potential thing that could have some benefit to patients. Whether I would what we know about interferon therapy and the cytokine, other symptoms of it with regard to at least symptomatology, whether it would be a good early therapy. I think the same effect could be done directly with an NLRP3 small molecule inflammasome inhibitor, of which I hope the manufacturers, because it's past phase 2 clinical studies in a number of conditions, are going to give it a try.
Thank you very much for that. We do have Fu-Dong back on with us from China, so I'd like to invite him to speak next. Do you have slides to share with us? Oh, there we go. Okay.
So I appreciate the opportunity to share with you data regarding the risk of infection in our clinic as well as in colleagues around the country. So this figure illustrating that the city and the province that are involved in the survey is color coded. For example, Hubei province in Wuhan.
Do you mind enlarging this? Do you mind enlarging this window? It's a little bit hard to see.
Okay. So
there we go. Fantastic. Thank you.
Yeah. So, for example, Wuhan in Hubei province is a city of 14 million people with over 50,000 infections. This is the official number we could got. And then there is a gradient in adjacent province that we are involved in the study. So you can see that we have 10 centers we are able to survey the patients, and including Hong Kong, where the DMDs are a bit different from what we are using in mainland China. So this is essentially the red illustrating the cities, the big MS centers, and the patients are being surveyed. Beijing and Tianjin is where my practice based. So we can see there's different number of cases. In Tianjin, it's a city of 15 million people. It's only 136 cases are being confirmed. It could be a little bit different now because this is a couple of weeks ago. We have new imported cases and which will be updated in a couple of days. So these are the location that where we have this data. We have a network called CM, and Chinese Medical Network for Neuroinflammation, where we have all major MS centers are being bound together so that we can share experiences and issues with MS care and research. So it's only about 2 years old. It's being evolving. So, but this is one of the few studies we carry out, and it has been doing quite efficiently. So this figure is very busy, but it essentially contain everything. So according basically to the number of cases in each city, Wuhan, Beijing, Guangzhou, Changsha, Hong Kong, Tianjin, Xi'an, and so on. So you see the population of each city are listed in the top line, and then the confirmed cases, the number of MS patients being surveyed. Unfortunately, only 78 in Wuhan because the situation was very hectic when we were doing this, and there was a few hands were able to make phone call to patients or review their questionnaire. Of course, very few regular MS patients will visit clinic because of all resources are being concentrated to deal with the infectious patients. So this is, I would say this is a small fraction of MS patients being surveyed in Wuhan in particular. In Beijing, there's this is a pool of 3 large hospitals with very large clinic. So they have a total 796 and so on. In Guangzhou, quite a large population. In Hong Kong, we have 160 patients. And then, these are the DMDs that are being used. It's very different from region to region, and of course from Hong Kong as well. And we don't have alantusmab Tisabri in mainland China, but we do have some of them, many of them in Hong Kong. And many patients have been exposed to rituximab for quite a long time in some of these patients. So, when we didn't record any patients so far. I should emphasize the questionnaire was designed in particular for asking any symptoms manifested as a COVID infection. If they have done the viral PCR, or you have any fever, something like that. And there's a fewer hospital visits during the past 3 months, during the very intensified period of infection. So this is the situation for MS. And for NMOSD, we have much larger patients. We have a total 3,086 patients being surveyed. And only 2 patients are reported, are confirmed with the the COVID infection, and one in Wuhan, the other one is in Beijing. They're relatively young, with very short period. One hasn't been treated with any DMD yet, but the other one was with None of them has been treated with anything. So they have mild symptom. Both were hospitalized. Both were positive test, were RA positive test, but they both recovered. So basically, this is everything. We are continuing following some of these patients and to see if any new cases are being reported. But in contrast to what has been reported to French, New York City, and we really didn't see much happening in our cohorts. I should emphasize that despite the few cases reported in our cohorts, it didn't really mean, I didn't really try to infer that the risk of infection is low. My assumption would be probably similar as general population, because majority of them has used one of the DMDs or the other. So, however, we did take very stringent measures from the very beginning to prevent infection, and the viral testing capacity was scaled up very quickly. Since the beginning of the February, we basically test everybody who wants to be tested or who exhibit any fever or symptoms of flu symptoms. And we did great efforts in ramping up online consultation so that they are persuaded, they're convinced not to go to the hospital, because we're dealing with a lot of COVID patients or suspected infected patients. So the hospital visits are really greatly reduced, and some of the infusions are done in a local caregiver. So the routine visits are really minimized. And for patients who are new or with suspected new attacks, we try to accommodate them with separate units so that they were separated from regular patients for the risk of infection. We configure large portion of my department and many other colleagues did so that we try to segregate patients with any suspected manifestation of infection so that they can be managed separately with different levels of protection. And lastly, with this, but not least, the hospitals in France are minimized. They are really controlled. Because the number, like in our city in Tianjin and Beijing, like were only 136 and a little more than 400 being reported or confirmed. The anticipation that these patients exposing to infection, the chances are not as high as other places. And the lockdown has been implemented very early, and it's really that anything that I haven't experienced so far in my lab is really that you're departing your apartment, you have to register when you will be there, where you go, how long you'll be away. So it's really that, in particular for patients with MS or other autoimmune disease where they have suspected compromised immune system, they have more stringent control for these patients to live where they reside. So I think that's in part the reason that we see relatively fewer cases in our cohorts. That's all I can share with you.
Thank you very much for sharing that and for being on with us at such a strange time for you. In the interest of time, we're going to move on to our Spanish registry. So Anna, are you available to share with us?
Yeah, I'm here. Hold on. Okay, can you see the slides? Well, hello everyone. I'm Ana Zabalza, from a neurologist at the TEMCAT.
We cannot see your slides, Anna. You click the share screen at the bottom?
Yeah, I've done that. Okay, no.
There we go.
Okay. Now, can you see them? Okay, so, well, what I was saying, Well, we wanted to do a survey in order to determine the prevalence of COVID-19 in our patients. As in many other countries, the access to PCR in Spain is very limited, and we're only testing patients with severe disease. So we were wondering, well, it is said that the prevalence is much higher than the actual one, and if with a survey to our patients, we would be able to detect those patients with mild disease, with suspected cases of COVID-19. So we did this survey. There's a web survey that we sent every 2 weeks by mail, together with an informed consent. And the inclusion criteria are basically any patient of our center that has accepted to receive emails from us. The variables that we're asking in the survey are typical COVID symptoms. We also added anosmia and ageusia because we think, well, for neurologists it's interesting, and also because it has been said to be very sensitive. We're also asking if they have been diagnosed by a physician of a suspected COVID-19. This means basically that patients have symptoms compatible with COVID-19, or if they've been confirmed with a PCR, if they've been hospitalized, and if they have, if they're living with people with symptoms or that have been confirmed of COVID-19. The idea of this is to get it together and then have the information to detect which patients are suspected COVID or probable COVID. What we did is use 2 types of definitions of what was a suspected and a probable COVID. We use the Catalan Health Department definition, in which suspected COVID is an any patient with an acute respiratory symptoms after, well, we added the after 1st February 2020, as the first case detected in Spain was in 13 February. So we assume that it was around that time that that COVID started. And a probable COVID-19 is any suspected case that is has had contact with a confirmed case. And a confirmed case is a PCR positive for SARS-CoV-2. In the WHO definition, the World Health Organization definitions, it's the definitions are quite different. A suspected COVID is a person with fever and acute respiratory symptoms, or acute respiratory symptoms and living or having had contact with someone with PCR positive, or acute respiratory symptoms and being hospitalized because of that. A probable COVID, that is definitely a change, is a suspect case, but that hasn't, that because for any reason the PCR has not been performed. And again, the confirmed case is a SARS-CoV-2 PCR positive. Okay. With this, on 15 and 16 of April, we sent 3,000 emails. From this, we got 625 responses until yesterday. We excluded 5 responses because some patients answered several times and there was one healthy subject. And over all that, we got 620 answers, which is a response rate of 20%. I say that this information we gathered all yesterday, so we haven't had time to go through all the clinical to cross it because it's anonymous information. So we haven't had time to cross it with the clinical information. So I'll go mainly through the results of the survey and some over some DMDs that I have had time to check. So 55 patients answered that they had symptoms, 13 that they had, they were said to be suspected of COVID-19, 5 were confirmed, 3 were hospitalized, 68 were cohabiting with patients with people with symptoms, and 8 were living with people with confirmed cases. The mean age of the 628 patients answering was around 45, and we had patients answering from 18 to 79 years old. The symptoms were the typical ones. Around 55% had cough, around 35% had temperature over 37, 40% shortness of breath, and around 30% had anosmia or ageusia. There were only 35% of patients that had 2 or more symptoms. In relation with the DMDs, this is modifying treatment, of the patients having answered that they had symptoms, there was around 67% that were on DMDs, but more or less there wasn't any difference in between first line and second line treatments. There were 19 in first line and 18 in second line treatments. In relation with the patients that had said that they were suspected of having COVID, there's a curious information that we haven't had time to check, is that only 5 of these patients said that they had symptoms. Of the confirmed cases, only 3 of the patients, of the 5 patients, had symptoms. And of the hospitalized patients, only 2 had symptoms or had these symptoms. We're not sure exactly why, and we have to make sure and contrast this information. The hospitalized patients, the 3 of them were on anti-CD20s, actually, on the second line, and anti-CD20s. Then, regarding the definitions that we said that we were used to define which patients were suspect COVID-19, using the Catalan Health Department, there are 55. That means 80, almost 9% of patients that had suspected COVID-19, and probable there were 7. And using the WHO definitions, there were 12 with suspected COVID-19 and 11 with probable COVID-19. The 5 confirmed cases, which as this definition is the same, then there's no change. Then as a discussion, well, there's clearly insufficient sample size. We only have 55 patients saying they have had symptoms, and we haven't gone through this information. But we have to consider for the future and for all of us doing survey patients that this information has to be verified and clarified with the clinical history, because as I mentioned before, there are some patients that have suspected COVID-19 but without symptoms, so it's difficult to tell how that is going to work. And also we have to, for future, homogenize the definitions as you have seen. If you consider, it depends, the cases of suspected or probable cases are going to change depending on what definition are we using. So I think in this case, it's going to be really useful in the future for all the countries that we're not using PCR in all suspected cases. Serologies are going to work, are going to be what it's going to confirm if patients have had it or not. So that's it. I've seen there are questions.
We unfortunately don't have time for questions. We're already over. Lots of great information from around the world to share, but thank you so much for sharing that study. Our final speaker for today is Celia. Celia, can you share what you have?
Yes. So that is good night. That is the first time that I have got the part of the patients of the Spanish register. That is the register of the Spanish Society of Neurology, and they are together with some patients from Madrid. It's only to show you that the most of the patients are in Madrid. That is 1/3 of the patients from the whole Spain are in Madrid. The second place is Catalonia, and there are 3 other small places, but 1/3 are everybody. It's like in Wuhan, we have 60,000, like in Wuhan, patients, so infected people. So that's the patients together part from Madrid and part from Spain, from the whole Spain. And they are 84. The age, as in the French and in the American, is 45. We have 28 males and 56 females. The duration of the disease is 10 years. And the most of them, the DDSS of is 2.5. The comorbidities, they were around 28 and, and hospitalized, they were 16%. They were no in the intensive care unit. There were no of them. And all of them, they are no more in the hospital. So that from these 60% of the patients, they are at home and they are not more in the hospital. As you can see, most of the patients, they were relapsing remitting MS. some of them secondary progressive MS and primary progressive MS. When we call the patients to the home, because we do telephonic consultation, the most of the secondary progressive MS, they are older and they are afraid, so that they are at home and they don't go. And as you know, in Spain, there is a complete block. You cannot go outside only for very important reasons. So that's most of the patients are really at home. And that, I think, is the reason why there are not many that they are infected. And in the second is because of the treatments. It's very similar to the other countries that we have from all the treatments. What is clear, so in the Italian court, the most of them they were more with Tefidera. In Spain, we use more Avallo, so that they are more with Avallo. But in general, we have from all the treatments. And the patients that they were in the hospital, they were with different treatments. We cannot see a trend of CD20 or a trend of second-line treatments in the hospital. So, and what we have the experience is that most of them, they recover very good, and we don't have many problems. I cannot say, but I know that in Madrid, there are 2 patients that they were secondary progressive MS and they die, but we don't have the data of the register. I don't have today the data of the PCR, but all of these patients, the most of them, they are confirmed PCR. And we are using not only the PCR to confirm the diagnosis, we are using the TAC, the CT thorax, because sometimes the patients, they have 3 times negative PCR, but they have a clear CT thorax and they are positive later. So that we are using both things, PCR and the RX or CT thorax, to know that they are confirmed COVID. But I will show next week the results of the PCR, because they couldn't give me today the informatic people.
Okay, thank you so much. Thank you, Celia. Thank you to everyone for bearing with us. As you can see, we had a lot of great information. We couldn't even contain it in 1 hour. Thank you especially to our presenters. Please join us next week. We'll have updates from other countries we didn't hear from today, and more current updates next week. Thank you, everyone. Bye.